All right, everyone. Thanks for joining us this week for GIM Grand Rounds. We're really fortunate to have Dr. Trevor Steinbach here to talk to us today about pulmonary function test interpretation for the PCP. Dr. Steinbach attended college at Montana State University in Billings, Montana, did medical school, residency, chief residency, and pulmonary critical care fellowship at the University of Washington. And then Dr. Steinbach's primary practice is in the general pulmonary medicine at the University of Colorado Hospital. Interests include pulmonary complications of stem cell transplant, bronchiectasis, as well as advanced COPD. In addition to general pulmonary clinic, he attends in the advanced COPD clinic. Inpatient roles include service of the inpatient pulmonary consult service and medical ICU. And then his academic focus is medical education and curriculum design. He's the clinic director for the Pulmonary Critical Care Fellows Clinic and the APD for the fellowship overseeing ambulatory education. Outside of work, he's an avid skier as well as cyclist. And so with that, and then for questions and answers, excuse me, Q&A, guys, as questions come up along the way, please go ahead, put them in the chat. Dr. Steinbach will pause periodically throughout the presentation for questions on the content at that point in time, and we'll have the final wrap-up Q&A at the end of the presentation as well. Now, Dr. Steinbach, please.
Well, thank you for the introduction, and thank you all very much for having me. It's really nice to actually see some familiar names. I think I share patients with many of you, and I sincerely hope that you find me helpful. I try as hard as I can to be helpful for folks. We're going to talk about PFTs today, and I tried to put this in the context of how it's helpful to have just to give folks in general medicine some interpretation skills and give you a little bit of peek behind the curtain on some of the nuances in PFT reading. I have no disclosures, and I'll just pause here on the audience response screen. The QR code will come up on the question slides if you miss it, but I'll give everybody about 15 or 20 seconds here to dig their phone out and grab that QR code. And like Steve said, I've got the chat window up here, so I'll try to keep my eye out, and then I will also pause for questions periodically throughout the slides. So what I want to do for this talk is I want you guys to be able to describe the components of PFTs, a stepwise approach to kind of basic interpretation, and then using that to identify key physiologic patterns of disease, because that's what we do in pulmonary clinic, and I teach the fellows and residents who are rotating with me to do all the time. And then importantly, what really matters is integrating these PFT results into common management decisions that you'll make taking care of patients with respiratory chief complaints. Before, I always like to start a PFT talk with a little bit of an acknowledgement. I think that this is something that has become increasingly known, not just inside the world of pulmonary medicine, but outside. I know that our nephrology colleagues are thinking a lot about this and actually beat us to it when thinking about things like GFR formula. But I'm going to talk about spirometry, which has, unfortunately, a really complex history. It is a critical tool that we use to evaluate pulmonary disease, define disability. We use it to diagnose disease, and it fits into classification. We also use it to follow diseases over time. So it's really indispensable, but it has a bit of a complicated history. Spirometry was initially invented in the 19th century in Europe. It was called a pulmometer. I'm going to start a campaign to revise that name. I think it sounds much more interesting than spirometry. And then in 1864 is when it really took off. A physician by the name of John Hutchinson gave it its current name, spirometer, and then he started to classify people and arrange them by occupation after measuring their vital capacity. And then he also made the correlations between age, height, and as well as their occupations with their vital capacity. Unfortunately, in the 1860s, physicians in the United States at that time who owned slaves started using spirometry to instill this concept of a pulmonary deficiency in Black enslaved persons. And then after the Civil War in 1869, there was a U.S. Sanitary Commission of Civil War soldiers, and that further perpetuated the bias. You can see the table on the right, how it was organized. A statistician in the 1890s further enshrined this and actually used it to say that Black people were unfit for freedom because of the differences that were found in vital capacity measurements. And even at that time, there were people who astutely pointed out that this was a social construct and not a racial or genetic difference. And then unfortunately, this became so enshrined that we used so-called race correction in our normal reference equations up until 2021. And that was when the ATS and others finally recommended removal and using a sort of a global reference equation. So just an example of how racism was enshrined in what we do. And I remember being taught by very well-meaning people who now teach this the modern way, but it was just enshrined that there was this difference in race between Black and white patients in terms of their vital capacity measurements that we now know is a social construct. So as of 2022, the ATS and the European Respiratory Society recommended against using a fixed adjustment factor for race. In 2022, the Global Lung Initiative developed a GLI global reference equation that is race neutral. And there are some serious implications to this, both using a race specific or a race neutral reference results in similar prediction of respiratory outcomes, but it does adopting a race neutral approach does reclassify lung diseases, occupational eligibility, and disability compensation for people. For example, more Black people or Black persons are classified as having restrictive disease and more severe COPD. More are eligible for disability payments and lung transplantation, and the opposite effect was observed in other populations. So as of now, most of us are using the race neutral equations, but as you'll see, there's a lot of variability in interpretation. So the outline for today, we'll talk about the anatomy of a PFT report. I think it's really important to just kind of walk through what all those numbers mean that you see on that report. And actually, I'm going to try and help you distill it down to what really matters. We'll talk about what normal values are, what the definitions of limitation, physiologic patterns, and disease, and then we'll go through some interpretation using the audience response. So the first thing I want to orient everybody to is the kind of components of a typical PFT report. If you send your patients to Anschutz for their PFTs, this should look very familiar to you. All PFT reports, while they look different, really have the same basic components. And sometimes they're in different order, but spirometry, both pre and post bronchodilator. The post bronchodilator is not always done, but this report is an example of both. There will be some graphical displays. The one that's constant is the flow volume curve, which is the loop on the left on the left of your screen there that shows airflow on the y-axis and then volume on the x-axis. And then there are various other displays that you might see. And then lung volumes, this is where we define things like restriction or hyperinflation, and then diffusing capacity. So these are the basic components of every PFT report, but as you probably have all seen, they come in different visual outlays or different orders, but these are the basic components. Spirometry identifies obstructive disease. It can suggest restriction. You need lung volumes to confirm that. The graphical displays help with sort of more of a visual depiction, and also helps us when we're interpreting to know if the test that we're interpreting meets standards for interpretation, because you have to have a good quality maneuver. Lung volume measurements is, like I said, where we define restrictive diseases and look for hyperinflation or air trapping. And then diffusing capacity, the other name is sometimes gas transfer, is where we assess the alveolar capillary surface area for gas exchange. Like I said, the layouts will vary. These are just from our UC health system in different locations, and you can see the reports all vary, but the data that's there is all the same. Sometimes, I don't know if you can see my mouse, but sometimes these columns are in different orders, but again, they're all there. And sometimes you just have to strain your eyes a little bit when you're looking at a report that's not familiar so that you can figure out where everything is is arranged. And then sometimes you'll see some of these other graphical displays that that are different in addition to the flow volume curves. So what do the columns actually mean? I think it's helpful to know that. So the reference or predicted column is the mean predicted value for a given patient based on their reference population, and I'll talk about what that means in a little bit. ULN and LLN are the upper and lower limits of normal. Now, these are newer adoption from the 2022 ATS guidelines that have been added, and even before that. But these basically define the bottom fifth and the top fifth percentile, and in between those is the normal range on the bell curve distribution. If you see pre or post, pre means that's what the patient did before they received a bronchodilator, and an if bronchodilator testing was done, the post is what indicates that. Percent predicted is simply what your patient achieved relative to that mean predicted value expressed as a percent. I thought I gave up learning about z-scores when I went into pulmonary medicine, but you guys do this all the time. But a z-score is the number of standard deviations above and below the mean, which we are, as of the new ATS guidelines, using to define the severity. So when you see us say mild, moderate, or severe, we're using z-scores where available. And then the percent change is the difference between the pre and post bronchodilator values. And there's a couple definitions for that too, which I will share. And as I mentioned, not everybody has adopted the upper lower limit of normal and z-score. So you may see reports that do not include those. And I'll try to help you understand how to interpret it both ways. Here's our report again. And of all of the numbers that you can see on that report, here's what really matters most. And these are the numbers that I look at all the time interpreting PFTs. We care about the FEV1 to FVC ratio. We care about the absolute value, but really the relation to the lower limit of normal. And then we care about the absolute values and the z-scores or percent predicted for the FVC, which is the forced vital capacity, the FEV1, the total lung capacity, and the DLCO. So when you take that into context, you take this really complicated and busy report and you distill it down to these key numbers. And it's not that the other numbers don't matter. They do help us when we're taking care of patients. But in terms of really defining the presence or absence of a physiologic impairment on a PFT, these are the numbers that really matter. The other thing that I'll say is when we're interpreting PFTs, the guidelines say that we're simply interpreting physiology. We don't have the patient sitting there. We don't have the history. And so really, and I hope that I'll sort of reinforce this later, that coming up with disease diagnoses really includes both implementing your clinical history, your patient, what you know about the patient, their symptoms, and then what the physiology shows on PFTs. So when we're interpreting it, I'm just in a tiny little office like this in the hub, and I'm just looking at the physiology, and then there's a lot of nuance that goes into patient care in between that. So let's talk about normal values briefly. Here's how we develop predicted values for what is normal for a given patient. And the way that I explain it to patients is that the things that constitute the size of your lungs are your height. Taller people have bigger lungs than folks who are of shorter stature. Age, sex at birth, and that is an area of ongoing research when we think about folks who've undergone a gender transition, because they may have done it at a younger age, and those hormonal changes do probably impact the lung volumes and the values that we see. And we don't know how to incorporate that, so we still use sex at birth for now. I mentioned we no longer include race, and then we talked about normal is between the 5th and the 95th percentile. And Dr. Martin, I actually do not talk about oscillometry for patients. It's something that we don't do, or we don't have the capacity to do, but it is something that's out there, and I think a very real problem, especially if you take care of patients who have various reasons why they can't perform PFTs. So defining the severity of PFT abnormalities, and again, this is based on the 2022 ATS guidelines. Um, so we talk about obstruction, restriction, and gas transfer impairments. So obstruction is simply defined as the FEV1 to FVC less than the lower limit of normal. The nice thing is the lower limit of normal is right there on the report, and so if the measured value is less than the lower limit of number value, obstruction is present by ATS criteria. And then the severity is defined by the Z-scores, and you can see the cutoffs down at the bottom. Restriction is defined as the TLC less than the lower limit of normal, and then severity by Z-score, and then gas transfer or diffusing capacity is the DLCO number less than lower limit of normal. And then again, we use the Z-score to define severity. Not all reports have Z-scores reported, and that's where we'll use the percent predicted to define the severity. And there are sometimes pretty significant differences where percent predicted would have often would have labeled somebody more severe, particularly for older patients. But the rationale for adopting Z-scores is that it acknowledges for more normal age-related changes. A bronchodilator response has historically been defined as an absolute increase in either the FVC or the FEV1 by 12% or more and greater than 200 milliliters. This changed in 2022, and it's now just an increase in the FVC or FEV1 by greater than 10% of the predicted value. If you're looking at the reports from Anschutz, that number on the right that says the percent change uses this formula. It's impossible to know whether other institutions use that formula or the older one, but usually if it's more than 10 to 12%, you can consider it a significant response is is the proper terminology there. But I've been on a bit of a soapbox on this one for the last couple of years, and there's increasing data that it can be helpful to define some diseases, but it really doesn't distinguish COPD from asthma. It doesn't, an absence of a bronchodilator response or an absence of a significant response doesn't preclude the use of bronchodilators. So while it can be helpful, for example, COPD is defined as a post-bronchodilator FEV1 to FVC of less than 70% by GOLD. So again, meeting strict disease diagnostic criteria. But again, for making clinical decisions, it's often not as useful. And I think folks are starting to move away from it a little bit as a strict definition of whether or not somebody has asthma, for example, because a lot of normal people have bronchodilator responses. A lot of patients with COPD who do not have asthma coexisting will have a bronchodilator response. So just take caution in over-interpreting that value. Well, there are several different standards that often we use. Some institutions are still mainly using the 2025 ATS and ERS standards. Many have updated their reports to reflect the 2022 update. And then, of course, GOLD, if you're taking, is specific to COPD, but does have some interpretation standards as a part of their guidelines. There is now a 2025 GOLD report, but the interpretation of PFTs is no different than the 2024 report, so no major changes on that front. This is where the percent predicted values are helpful, or the cutoffs for percent predicted. This was based on the older 2005 ATS and ERS guidelines. They defined obstruction and restriction the same. So the ratio less than the lower limit of normal or the TLC less than the lower limit of normal. But the severity was graded by the percent predicted FEV1, and you can see the cutoffs there to the right, and there are a lot more than mild, moderate, and severe. GOLD is, again, specific to COPD, and this, instead of using the lower limit of normal as the cutoff for FEV1 to FVC, they recommend using a fixed ratio of FEV1 to FVC of less than 0.7 or 70%. They do not define restriction, and then they use the GOLD 1 through 4 classification, or mild through very severe, based on the FEV1 percent predicted. So these are there for your reference. So obviously this creates some confusion and a lot of inconsistencies, which is why you might have a patient who got PFTs in one institution where they said the obstruction was mild, and then at a different institution where they said it was moderate, even though the absolute numbers are the same. And so if you see variations in our interpretations, that may be why, and it's helpful to look at the absolute numbers for the patient values. What's the difference between this fixed ratio versus the lower limit of normal cutoff for FEV1 to FVC? So on the y-axis here, we have the FEV1 to FVC ratio, and on the x-axis is age. As we get older, the lower limit of normal, so the normal FEV1 to FVC, actually decreases with age. And that's what the ATS and ERS are trying to account for, is these age-related changes in PFTs, where GOLD just uses the fixed cutoff of 0.7 or 70%, regardless of age. And the advantage is there's an advantage to either. If you use a fixed ratio of 70%, for example, we may miss a normal FEV1 to FVC in young patients, may be above 75, for example. And so if we're using a fixed cutoff of 0.7, that may actually miss some clinically relevant obstruction in younger patients. Whereas using the fixed ratio may be overly sensitive in patients who are older or more advanced age. And so ATS and ERS, because they're making these interpretive guidelines for throughout the age spectrum, whereas GOLD is really focused on the most sensitivity to diagnose COPD, which is why they have arrived at different recommendations for what the cutoff for obstruction is. I will say for COPD specifically, the fixed ratio seems to correlate better to outcomes, and I'll actually, it was a good transition to the next slide. So how do we reconcile these? For most patients, I will apply the ATS 2022 guidelines, and this actually is not infrequent. When I'm reading PFTs for a week, I will see several per day that fall into this little gray area where their FEV1 to FVC ratio is above the lower limit of normal, but below 70. And I will interpret those as not having an obstruction because they are not below the lower limit of normal. But if you're seeing the patient, they're short of breath and they have a 20-pack year smoking history, they may very well meet the criteria for COPD and have obstruction that way. So again, for most, I use lower limit of normal. For restriction, I use lower limit of normal as the cutoff. And then I will use the severity based on Z-scores if they're available, and if not, I'll apply percent predicted. For patients who I suspect having COPD, I will use the fixed ratio cutoff. So even though that official PFT report will say no airflow obstruction because their FEV1 to FVC is technically above the lower limit of normal, if I'm seeing the patient, they have a significant exposure history that would predispose them to COPD and they're symptomatic, I will classify them as being obstructed in the exam room. And the other time to consider is a young patient with a really high suspicion for obstructive lung disease. You might want to take a look at both and again, apply it to the patient that you're seeing. So now we're going to transition into talking about what defines the physiologic patterns and what diseases correlate. So this is the three-step approach to interpreting PFTs, and I think it's just the easiest way to distill, have a systematic way to look at a PFT report. Many of us have a systematic way to look at chest radiographs, and so applying a similar systematic report to PFTs helps you not miss anything. And so really step one is there airflow obstruction? And you look at the FEV1 to FVC ratio, determine whether there's a significant bronchodilator response if that testing has been performed, and then whether or not there's hyperinflation or air trapping, just as we define the physiology. Step number two is there restriction, and that's simply the TLC less than the lower limit of normal. And then we kind of try to classify that as intraparenchymal, meaning in the lungs, or extraparenchymal, meaning pleural, chest wall, abdomen. And then is there a gas transfer impairment? And that's where we look at the DLCO. So you'll find obstruction in spirometry, hyperinflation and air trapping in lung volumes, restriction in lung volumes. The parenchymal versus extraparenchymal is where we'll look at the DLCO. And again, this helps us classify our physiologic patterns. And there's 5 that you should be aware of. And I think these are well within the purview of anybody. They're pretty easy once you get that sort of interpretation system down. And so these are the 5 patterns that I want to talk about. So normal, obviously everything's between the lower limit of normal and upper limit of normal. The FEV1 to FVC is greater than the lower limit of normal, and then the flow volume curve has a normal contour. The good news is most reports will make abnormal numbers red. And just because they're red doesn't mean there's an abnormality or it doesn't fit a physiologic pattern. But if you look at a report and you don't see any red numbers, then usually it's a good 10,000-foot view and is really reassuring. So obstruction we already talked about is defined by the FEV1 to FVC ratio of less than the lower limit of normal. Again, you can use that fixed cutoff of 70 in older patients with a higher pretest probability of COPD. Other features that you may see in the presence of an obstructive pattern is hyperinflation, which is the total lung capacity greater than the upper limit of normal, or greater than the 5th percentile. And then air trapping is where we look at the residual volume being greater than the upper limit of normal. And so we'll often see that in patients with bad asthma or COPD. And then looking at the DLCO, again, the lung parenchyma in the alveolar capillary membrane, diseases like asthma or chronic bronchitis will have obstruction with a normal DLCO. Diseases like emphysema, where there's a lot of parenchymal destruction, will have obstruction and typically a low DLCO, usually in proportion to one another. And again, I just want to hammer home that bronchodilator response does not distinguish asthma from COPD. That's really down to our clinical history and the patient's sort of demographics. A restrictive pattern is defined by the TLC less than the lower limit of normal. And if the DLCO is also low, we think a parenchymal process. And if the DLCO is low, we think that the lungs are restricted because of a problem with full lung expansion, either neuromuscular weakness where a patient can't achieve a full total lung capacity, chest wall disorders, scoliosis is a good example, and we do see obesity impacting lung volume measurements, and so that is a cause of restrictive lung disease. It's obviously a diagnosis of exclusion, but it can cause restrictive pattern physiology, usually with a normal DLCO, and that can sometimes be a clue. Other values, so usually the FVC on spirometry is low, but the low FVC alone only suggests restriction. You really need that TLC to confirm. And I do see that on reports sometimes being erroneously called a restrictive pattern. It suggests restriction having a low FVC, but again, you need lung volumes to truly define that. Some patients can have a mixed pattern, and that's where they meet the definition for both obstruction and restriction. So the ratio is less than the lower limit of normal, and their TLC is less than the lower limit of normal. And that is called a mixed obstructive and restrictive pattern. How to define the severity varies. There's not a strict way. Usually I pick the Z-score that's lowest to define the severity. So if the FEV1 to FVC Z-score is lower and it fits into moderate, but the TLC is mild, I'll say it's a moderate mixed obstructive and restrictive inhalatory defect. DLCO can be variable. It really depends on the cause. And usually these are mixed disease processes. So for example, a patient with COPD plus significant obesity. Sometimes we'll see mixed disease processes like COPD and ILD overlap. So IPF and COPD commonly overlap. And sometimes those will actually balance one another. And the only clue is that the DLCO is very low. So again, looking at the patient, the radiographic and interpreting that with context of the PFTs. And you need both the spirometry and lung volumes to define a mixed pattern. A low FVC is not a mixed pattern without lung volumes to confirm that. And there's a case that highlights that later. And then the final pattern is what we call a pulmonary vascular pattern. And this is when you see an isolated reduction in the diffusing capacity with normal spirometry and lung volumes. Now that you should think about pulmonary vascular disease in this case, but there are other things that can cause an isolated low DLCO. Very early ILD, the DLCO is typically the first thing that will drop before the patients develop restriction. Anemia, because if there's not enough red cell volume to take up the carbon monoxide during the DLCO maneuver, the DLCO will be falsely low. and it can be corrected for anemia, actually, if we have a recent hemoglobin. CHF or heart failure can cause a isolated low DLCO, and then, like I mentioned earlier, combined emphysema and fibrosis, because the restriction and the obstruction will eventually balance one another out, but the degree of parenchymal destruction will result in a very low DLCO. And then we're gonna do some interpretation, but I'll pause here to see if anybody has any questions. Pop them in the chat or unmute yourself if you like.
No questions in the chat yet, but I'll go ahead and unmute myself and ask one, Trevor. Um, Air trapping and hyperinflation. I learned about those years and years ago. What's the utility in them? So, for example, is this something that if we're on the fence, could this be an obstructive process? We're combining that along with the clinical information. Do you use it for therapy, something else?
Yeah, great question. And yes to both. I think it can sometimes, in patients who, again, we define diseases and we define ventilatory impairments on PFTs by a strict cutoff. But it gets at the importance of integrating the patient history with the PFTs. And, some patients with significant symptoms may not fit into that neat disease classification. And so sometimes we'll look at that, and it may be usually it's almost always seen an obstructive lung disease. Sometimes you'll see an elevated RV because of neuromuscular weakness, because the patient can't exhale all the way. So there are other reasons, but yeah, sometimes it can be a tiebreaker. Where it does, it can also be a lot of air trapping can cause a lot of symptoms for patients. So we can all think of the patients with the barrel chest and COPD, and if they have a lot of air trapping, their diaphragms are very flat, and they're, when they are contracting, sometimes going in the opposite direction, and so that air trapping can sometimes explain why a patient with bad emphysema has severe dyspnea. It can translate to sometimes even syncope. And then where it matters for therapies is bronchoscopic lung volume reduction and surgical lung volume reduction, which isn't as common. But in patients who are fully maximized on their inhaled therapies that have a lot of air trapping and hyperinflation, are folks that we sometimes think about referring for bronchoscopic or surgical lung volume reduction. So they can be helpful in that regard. To Matt's question about DLVA. So this is another soapbox of mine. You will often see, and it's common in our among our faculty, to correct for the DLCO. So in order to measure an accurate diffusing capacity, the patient has to take in around 90% of their TLC during that maneuver. And you can imagine if they get less gas in to their chest during the maneuver, the DLCO will be falsely low. And so the DLVA takes the diffusing capacity divided by the volume that the patient inspires. And some folks will use that as a correction. I will tell you that the 2022 guidelines specifically say in the text that the DLVA is not a correction factor for inadequate inspiration during the maneuver. It can sometimes be, if the VA is low, if the VA is less than about 90%, 85 to 90% of the TLC, then you can say that that might be part of it, but the relationship isn't linear. So we can't say that if, the DLVA is normal, then they must not have a gas transfer problem. And so I think that that's a really great question, and thanks for letting me make that point, Matt. You must be a plant here. So yeah, so to Dr. Lee's question, full PFTs in our system will indicate you'll get spirometry, lung volumes, diffusing capacity. If you order full PFTs with the bronchodilator, then you'll also get the bronchodilator testing, as opposed to ordering just spirometry or spirometry with a DLCO. You can't get just lung volumes because you need spirometry actually to measure the lung volumes. And so it depends on your clinical question. If you are just trying to diagnose somebody with asthma or COPD, you can just get plain old spirometry, and you can put in that order for just spirometry. Whereas if you're not sure somebody has dyspnea and you're kind of trying to classify what's going on and you want it all, then you would order full PFTs. And so that's the different. Hopefully I answered that question. To Dr. Williams, the mid flows or the 25-75, that also highly variable, in the 2022 guidelines have removed that. So we historically have used a low mid flow or 25-75 to indicate early airflow obstruction that doesn't quite meet the strict criteria by ratio, but there's a lot of variability in those measurements, and so using those to define early obstruction was removed from the 2022 guidelines. My colleagues in lung transplant still use it to define early obstructive or airways rejection. So there are some niche areas in pulmonary medicine where it's still used. But I think for strict management or defining obstruction, we don't use it when we interpret it. When we see the patient again, sometimes, again, if your pretest probability for, say, asthma is super high and they don't quite have obstruction, but the mid flows are consistently low and the airflow volume loop looks really scooped, then maybe that's enough to try them on treatment again to make a clinical decision there. And as more and more yes. So the guidelines do say what should be included in a report. And it is interesting. Having patient access to data is overwhelmingly a good thing, but it does create more questions. I've had some patients who say, "Why are all my values low?" They have an L next to them, and I'm like, "Oh no, that's the unit. It's liters, and so they're not all low." And so I think point well taken, though, that having a more patient-friendly report would be something to consider, given that patients can see those. We haven't specifically worked on it. On the other end, we need to have all of that data there for interpretation guidelines, and so I'm not sure how to reconcile those two things, but that's a great point as well. All right, so this slide is here just as a reminder for interpretation, and we're going to go through, I think I have 6 cases that we're going to go through to make a couple key points. And so here's our first case. So queue up, get your phones ready. We're going to do audience response. I'll have the QR code on the question slide here in just a second, again, in case you need it. So case 1 is a 72-year-old woman with dyspnea on exertion. She has a 35 pack year smoking history. She quit 10 years ago. And you can see on the left there are the parameters, and then reference again is the normal value, LLN is the lower limit of normal, pre is her values, red means they're abnormal. The Z scores are there. The post value is after bronchodilator. Percent change, remember, anything greater than or equal to 10% change is considered significant there. So I'll let everybody look at those for just a second, and then we'll move on to the question. All right. So the disease process most likely to account for these PFTs is asthma, emphysema, chronic bronchitis, idiopathic pulmonary fibrosis, or bronchiectasis. And so the poll should be open. Let's see. I think you should be able to vote, and I can see. There we go. Oh, I locked it. All right. This is the joys of poll everywhere. It works great when it works. All right. And so the correct answer here was emphysema. And so here's our interpretation. So 35 pack year smoking history. First question, is there obstruction? Yes. The FEV1 to FVC ratio is less than 0.7, and also below the lower limit of normal, which for this patient is 64. And there's no restriction. The TLC is between the lower limit of normal, upper limit of normal. I didn't have the upper limit of normal on here just for room. And there is not a gas transfer, or there is a gas transfer abnormality, and we can see that the diffusing capacity is much lower than the predicted value. So this one is just sort of looking at the typical obstructive pattern of lung diseases. So the classic COPD PFT pattern is you have to have airflow obstruction. That is required for diagnosis of COPD. And for COPD, again, we can use that fixed cutoff of less than 0.7. And then they may or may not have hyperinflation and air trapping. Again, it just helps to question earlier. It just kind of helps us define that pattern of abnormality. Admittedly, we treat COPD, whether there's chronic bronchitis or emphysema, the same with bronchodilators. And then low DLCO due to alveolar destruction. The chronic bronchitis pattern, we typically will see an airflow obstruction with a normal DLCO. And that actually is a similar pattern to what you'll see with asthma. And then as we've all had burned into our brains from med school boards and other, you'll see this scooped flow volume curve as well. All right, so case 2, or I'll pause there if there's any questions about case 1. Just give you 30 seconds to throw something in the chat real quick. Okay, so case 2 is a 69-year-old gentleman with progressive dyspnea exertion and a dry cough. He is a former smoker, 15 pack years, quit over 20 years ago. And here's his spirometry, and we only have pre-bronchodilator values here. Okay. What is the next best step in management? Start a LABA-LAMA, transthoracic echocardiogram, high-resolution chest CT with ILD protocol, or a PA and lateral chest radiograph. See if we can make it to 10. And to Dr. Moles, how common is it to see normalization of FEV1 to FVC in severe COPD? I would say that would be uncommon. Again, the low ratio is required to make the diagnosis. What we will see is that as the air trapping becomes worse, the FVC will become low, and it kind of makes you wonder about a mixed pattern, but it's not. But the ratio still generally has to be low. Okay, and here is what everybody said. So most folks wanted a CT, a few wanted an X-ray. And the correct answer was high-resolution chest CT, although I don't think it'd be wrong to get a chest X-ray here, but we'll talk about why I think a CT is the best answer in this situation. So again, our interpretation, is there obstruction? No, the FEV1 to FVC ratio is 79 in this patient, which is higher than both 70 and the lower limit of normal. Is there restriction? Yes, TLC, less than the lower limit of normal. And is there a gas transfer abnormality? Also, yes here. So this would be a pattern that would be highly concerning for interstitial lung disease, which is why I think getting a CT is the best answer. Chest X-ray wouldn't be wrong, but I think the way that I think about it is if you get a chest X-ray and it's normal, you're still worried enough, you'll probably get a CT. And so I think either way would probably be headed to a CT in this patient's case, because we really need a CT to figure out what interstitial lung disease somebody has. So this gets back to how we sort of think about restrictive lung disease, and that's sort of parenchymal or extraparenchymal. Now, these distinctions are not perfect. So if you still have a high suspicion that somebody might have interstitial lung disease, then a normal DLCO, shouldn't be the tiebreaker. But what I would say is if you see restriction with a low DLCO, think parenchymal lung disease. And I will say most of the time, as in the patient in this case, we will pursue a high resolution chest CT. If we see restriction with a normal DLCO, we think more about extraparenchymal processes. So these are chest wall problems that cause the lungs to be squished, for lack of a better word. And this is where we think about chest wall deformities, spinal deformities, neuromuscular disease like ALS or diaphragmatic paralysis, and then again, obesity. And so you can see the differences here. We have a normal lungs and a thick chest wall. Here we have normal chest wall with diseased lungs and diseased lung parenchyma. And then if you guys have questions, just pop them in there and I'll answer them as we sort of move along. And then we'll hopefully have time at the end. All right, so this is case number 3. We have a 66-year-old man with known severe COPD who's experiencing worsening dyspnea and frequent exacerbations. So I'll give you a moment to look at these PFTs. All right, so this pattern on spirometry is best described as obstruction alone, restriction alone, mixed pattern of obstruction and restriction, and obstruction is present, but I need more info. A couple more. All right, so we have some votes for mixed pattern and some votes for want more information. And this is the example that we talked about and sort of gets to Dr. Moll's question a little bit. So obstruction is present by definition, but we need more info. There is a reduced FVC to FEV1 to FVC ratio. So by definition, there is obstruction. Is there restriction? We don't know because we don't have a TLC. The FVC is low, which makes us wonder if there's a mixed process, but we don't know for sure. And there's also a gas transfer abnormality. But if I put up the lung volumes for this patient, you can see that the patient's TLC is actually supranormal by a lot. And actually, this is hyperinflation. And this is where we get patients with really severe airflow obstruction. And when you think about the maneuver that they're doing to measure the forced vital capacity, they're breathing out as hard as they can, and the PFT tech is yelling at them to blow, 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 blow. And normally we get most of our air out in the first second or two, and then we want to see this plateau where there's no more airflow and our lungs are empty at the 6-second mark. But in a patient like this with severe obstruction, because of the severe obstruction, they're not actually able to empty their lungs. You can see it goes all the way out to 8 seconds almost, and air is still flowing because this line has not plateaued. And so the FVC will be low. And then when we measure lung volumes, they're actually hyperinflated. So this is why, and this one is specifically here to make the point that the FVC, if it's low, we really want lung volumes to know for sure whether or not there's restriction. Once you've defined it on PFTs, then you can follow it with spirometry because it doesn't matter as much. But in terms of defining it initially, you want both. And so here's an example of a true mix process. This is a 71-year-old who had a history of lung transplantation for IPF and is seen for follow-up. They have all sorts of weird patterns of abnormality because of the lung transplant, but we can see that both the FEV1 to FVC and the TLC are low when we have all of these measurements. So this would be an example of a mixed process. All right, move on to case 4. 79-year-old former tobacco smoker, 40 pack years, who's got progressive dyspnea on exertion and a productive cough. So what is the most likely diagnosis? COPD, IPF, asthma, chronic bronchitis, obesity. Any last minute votes? So we've got COPD, chronic bronchitis, obesity as possibilities. Um, I would classify this patient as having COPD, and I'll tell you why, although it may very well be a chronic bronchitis pattern. So for those of you that voted for chronic bronchitis, not purely wrong, but I think you would say that this patient has COPD. And I put that again, this is the example, and I see this a lot. And I hope that it's helpful for you guys when you're getting PFTs. If you have a patient where you highly suspect COPD, but when I send you back the report, I say no airflow obstruction, as I would in this case, because I'm using ATS criteria. The patient's FEV1 to FVC is 65, so is below the fixed cutoff for gold, but is above the lower limit of normal for ATS criteria. So this one clearly fits into that gray area where you suspected COPD. I said there's no obstruction, and now you're wondering like, well, what the heck do I do? But be reassured that if this is less than 70 and you think the patient has COPD, that you can start them on management so you can make a management decision based on that. So again, just to highlight that this comes up a fair amount where patients fit into this gray area between gold and ATS. And so if you see that ratio of less than 70 and the flow volume curve looks obstructed, then by all means start treatment for COPD because they meet the gold case definition criteria. So when you see an abnormal flow volume loop, like a notch or flattening, do you repeat PFTs? Maybe. So the secret is that this flow volume curve that you get is just whichever one of the many that the PFT tech picks to display, and they'll usually try to pick the prettiest one. If you ever have a question, reach out to us or the PFT lab because we can go back and look at each individual loop because sometimes it's just a one-off where maybe you see flattening on that bottom and you wonder about vocal cord disease, for example. I didn't even dive into that for this because it's a really challenging thing to think about in a 60-minute talk. But if you are worried, just reach out to us or the PFT lab and we can go look at the other curves to see if it's consistent throughout. That's a great question. And case 5, 72-year-old woman, progressive dyspnea, weight gain. Her BMI is 40 over the last several years. She has a normal chest CT. She got a PE scan when she went to the ER for dyspnea, as so commonly happens. Here's her PFTs. Give you a second to look at those. What most likely accounts for her abnormal PFTs? COPD, ILD, neuromuscular disease, or obesity? Okay. So this is a patient who has PFTs that are affected by obesity. I think neuromuscular disease is a reasonable concern, and if there were clinical history, you'd definitely investigate. So both of those where you guys were all honing in was that this is a restrictive pattern with normal lung parenchyma as indicated by our normal DLCO. And then we also have a normal chest CT. And so as we think about that distinction between parenchymal and extraparenchymal restriction, she fits into the extraparenchymal, which is either neuromuscular disease or significant obesity. There are a couple things in here. Often, like I mentioned, folks with significant neuromuscular disease will have a more elevated residual volume because they can't fully exhale. I think for this one, it's obesity. But if there were clinical signs concerning for neuromuscular disease, I would certainly further investigate that. And with the key points or key teaching points to take away from this case is that obesity definitely causes restriction. I will tell you it is a diagnosis of exclusion. We probably do get more CTs than we need to just to reassure us because I'd much rather get a few extra CTs than miss clinically significant interstitial lung disease. But after you've had the imaging and have reassured yourself there's no neuromuscular disease. And this pattern of PFTs, we can say that it's probably due to the elevated BMI. The other clue here is that the FRC is low. In folks with neuromuscular disease, the normal balance between the chest wall and lung compliance is still relatively normal. So they'll often have a normal FRC, functional residual capacity. That's the resting volume and exhalation. Whereas in patients with obesity, because of the added chest wall weight, the FRC will often be low. So that's the other tip off here to obesity as opposed to neuromuscular disease. None of these are make the distinction based on the PFTs alone, but when we put the whole clinical picture together, that's how we arrive at that diagnosis. Last case, 70-year-old man with progressive dyspnea on exertion, and here's his PFTs. Right. Oh, sorry about that, y'all. What is the next best test for him? Baden. All right, so options, methacholine challenge or transthoracic echo were our leading contenders. I recommended TTE for this patient, and here's why. So he has no obstruction, no restriction, but an isolated low DLCO, even corrected for hemoglobin. And so this is our isolated reduction in DLCO. We worry about pulmonary hypertension, but there are other things that can cause this. So if you get an echo and rule that out, then just some other things to think about. In this case, we had corrected for the low hemoglobin. The echo will help us look for CHF. Early ILD is still a possibility. And so if your workup is negative, you might think about a CT scan. And then the inadequate volume inspired, but to the earlier point, it doesn't necessarily, the DLVA doesn't correct for that, but an inadequate volume certainly can cause a gas mixing impairment. So, in conclusion, familiarize yourself with the reports from your system and us. Please reach out if you have any questions. Assign a pattern to the PFTs you review. Again, obstruction, restriction, mixed, pulmonary vascular, and making a disease diagnosis is more than just what we're doing when we're interpreting the PFTs. I can read them and think, oh gosh, this sure looks like emphysema, but I'm not seeing the patient, and that's where integrating that information is helpful. And it also helps in the situations where patients don't fit neatly into one of the patterns, which is not uncommon. So I'll stop there for questions. Please email me if you have any questions about PFTs or pulmonary in general. If we share patients and if you ever have questions about our mutual patients, email me. I'll secure chat as much as we love to hate it. But please, I am always available. Don't hesitate to reach out. I like talking about patients. This QR code is an interpretation guide that I made for our faculty when they're interpreting PFTs here. And so feel free to take a look at that and save it for yourselves. And I'll stick around for questions. I know folks probably have to get to clinic, but if you have any questions, I'll stick around for a bit.
No question from me, but it was a really helpful history, I think, of how the pulmometer started and spirometry started, and then taking us through some of those recent updates for ATS especially was really, really helpful. So thank you, Trevor.
My pleasure. Like I said, I love to talk about this stuff or anything pulmonary in general. So if folks have any questions, never hesitate to reach out to me. Current patients, patients that we don't follow yet, anything at all.